All right, good afternoon, everybody. We're going to try to start on time and keep this going. And unfortunately, I hope, please feel free to bring a beer or wine. Let's try to welcome the last session of the first day. So this is Quick Shots 2 as some introductory. Presentations are 2 minutes. Questions are only 2 minutes. So we have 20 presentations, so we have to keep it going. The only place to answer questions is the microphone there. So if you have a question, please try to move to the center mic, and obviously give your name and institution. So to start the session off, our first presentation for this evening is the use of autologous blood patch in pediatric patients with a persistent air leak, presented by Dr. Pruitt from Salt Lake City.
Thank you, and we have no disclosures. The use of autologous blood patch pleurodesis for persistent air leak has been well described and is used commonly in the adult population following thoracic surgery. However, little is known in a pediatric population. There's a single previously published case series, and patients waited a median of 21 days prior to undergoing blood patch. So our research question is early autologous blood patch safe and effective in a pediatric population? We performed a retrospective review of all cases at a single institution over a 3-year period, and we defined a persistent air leak as an air leak present 7 days after initial surgery. Our protocol infused 2 cc's per kilo of a patient's own blood into their chest tube, which was then clamped for 4 hours, with strict instructions to nurses to unclamp the tube if the patient developed respiratory distress, and then we assessed for resolution of air leak. We had 10 patients who underwent a total of 17 blood patches, and the indications for the procedure included blebectomy, need for lung biopsy, resection of a known malignancy, empyema, necrotizing pneumonia, and congenital lobar emphysema. The median age of our patients was 12 years, and they waited a median of 7.5 days between surgery and their first blood patch. Their second blood patch occurred after 2 days if the first one was unsuccessful, and they waited a median of 3.5 days prior to chest tube removal. And we are compliant with our protocol with a median volume infused of 2 cc's per kilo. We had a 40% success rate after a single patch, which improved to 90% after a second blood patch. In conclusion, autologous blood patch for pediatric patients is effective, safe, and it can be done early. We reduced the time from 21 days to 7.5 days with similar success rates. Thank you, and I'll take any questions.
Paper's open for questions, and I'll actually ask one. Couple things. How many, you had the number of procedures, but how many thoracic procedures overall, was that part of? And what was the time between the first and second blood pressure? For the ones who failed it, how long did you wait?
Thank you. There were, I don't know the exact incidence of persistent air leak in our patient population, but this was out of several hundred thoracic procedures over this period, and they waited a median of 2 days between blood patches if a second one was needed.
Okay, thank you.
Thank you.
Our next presenter is Dr. Mina Wick out of Chicago with a study from Portland and Phoenix as well, minimizing variance in pediatric surgical care through implementation of a spontaneous pneumothorax management protocol, a multi-institute study.
Thank you. We have no disclosures to make as well. So primary spontaneous pneumothoraces are a fairly common problem that we face, but whether the primary treatment should be operation, a tube thoracostomy, or simple observation alone is unclear. In an effort to standardize care at the hospitals we work at, we implemented a pneumothorax protocol with 2 key decision points. The first is observation alone for small asymptomatic pneumothoraces, which we defined as anything smaller than 20%. Pneumothoraces that were larger than this were still treated with a tube thoracostomy. The second decision point was early operative management of patients who still had a persistent air leak at day 3 or 4. A chest CT could be obtained at this time at the discretion of the attending surgeon. We hypothesized that with this protocol, we could improve resource utilization and patient outcomes, as well as show that observation of small pneumothoraces could be safe. we performed a retrospective review of all the pneumothoraces that were diagnosed 2.5 years before and after the protocol implementation. The primary outcomes that we were looking at were the length of stay, whether or not the patient needed any operation, and pneumothorax recurrence. The secondary outcomes we looked at were whether or not they needed a chest tube at all, and the use of thoracic CT. We identified 46 primary spontaneous pneumothoraces, 20 before and 26 after the protocol implementation. When we compared these two groups, we saw that there was no difference in primary outcomes. However, there was a significant decrease in the use of thoracic CT after protocol implementation. In a separate analysis, we looked at the 15 patients who were initially managed with observation alone. 60% of these patients never needed any chest tube or a subsequent operation. When we compared these patients to the patients who did need some sort of procedure or operation, they had a significantly lower length of stay and cost of hospitalization. So in conclusion, we showed that implementation of a protocol that includes observation for small asymptomatic pneumothoraces can be safe and result in decreases in resource utilization. Future studies will be needed to look at how to optimize the efficacy and patient selection in such protocols.
Do we have any questions?
I'll ask a question. So obviously hurting surgeons like hurting cats. So how hard was it to get everyone to agree on a protocol? And can you quickly explain the process of that?
So this is part of a larger protocol implementation at OHSU, where these protocols are driven by the fellows. They pick which projects they would like to target, and they have basically come up with a protocol after reviewing all the data themselves and present it to the attendings. And then there is sort of a general roundtable about which details of the protocols attendings feel strongly about, disagreeing with, agreeing with. But since it's mostly driven by the fellows, the bickering is minimized.
Politically correct done.
Thank you.
We have one question.
Yeah, hi, David Lazar from San Diego. Excellent talk, really neat protocol. I was wondering if you have any long-term data. It seems like 30% of your patients sort of failed observation and went on to surgery, but do you have any long-term data to say that that 30% stayed a constant number or increased over time?
So it's been about 2.5 years since we implemented the protocol, and so the longest follow-up from the new group has been about that time period. Two of the ones in that 15 actually were from pre-protocol, so we do have some patients who have been observed for 5 years under that, but it's hard for us to tell at this point with the numbers about what the change in failure rates is going to be.
Thank you.
Thank you very much.
Thanks.
Our next presentation will be evaluating patient compliance of pectus carinatum orthoses with temperature sensor, presented by Alyssa Port from Chicago.
Pectus carinatum can be corrected using external compression orthoses. However, compliance is limited to report by patients and families. Temperature sensors can assess actual brace wear time. Our institution uses white light scanning to create a 3D image that can be used to evaluate PC deformity before and after brace intervention. The HMI is calculated by taking the mediolateral diameter of the chest divided by the anterior-posterior diameter at the highest point of the carinatum. This is a ratio that demonstrates severity of deformity. Improvement is measured by change in HMI. Temperature sensors are implanted into the patient's brace and take a temperature reading every 30 minutes to objectively assess compliance. 41 patients had complete temperature sensor data. The number of hours each patient wore their brace per day correlated significantly with improvement. However, the number of days braced did not correlate with improvement. Patients who wore their brace for 8 or more hours per day saw significantly greater improvement than those who wore their brace for less than 8 hours. Patients who wore their brace for 12 or more hours did not see significantly greater improvement than those who wore it for 8 to 12 or less than 12. In conclusion, brace wear time of at least 8 hours is ideal. Wear time of 12 or more hours does not show more improvement. Hours worn per day may be more important than the number of days worn. Temperature sensors have the potential to evaluate patient compliance of PC orthoses and measure the impact of wear time on deformity. Thank you.
This paper is open for discussion. I'll once again take the liberty. So obviously compliance is a major aspect. 2 questions. Did you have something that, for the kids especially, like did they were able to see it on an app? And number 2, did you happen to look at, did the patients actually fill out a thing like how often they said they were wearing it? And did that correspond to actually what you were measuring?
Yeah, so no app, but we print out the report for them so they can see that. And then our pediatric surgeons and nurses in clinic ask how long they've been wearing it so we can check to see if they were telling the truth.
David Huber, Wake Med Children's. Nice presentation. Thank you. It brings a question up. One of your conclusions is that they only wear it for 8 hours a day. They get better results than wearing it for longer in the day. That is a little different than what a lot of our orthotics are saying. We're trying to get them to 18 to 20 hours a day. So can you speculate on why you're seeing better outcomes for wearing it less time?
Right.
Thank
So patients who wore their brace for at least 8 hours saw significant improvement, but more than 12 hours wasn't any more improvement. So we think they should wear it for at least 8 hours, and more than 12 might not be beneficial. We do also need more research because we had very few patients who actually wore their brace for more than 12 hours.
Out of curiosity, did the data feedback to the kids change behavior after that?
Sometimes, yeah.
Thank you.
Thank you.
Our next presentation is by Dr. Priscilla Chu, Anesthetic Exposure and Neurodevelopment Outcomes in Term Infants with Esophageal Atresia and Tracheoesophageal Fistula out of Sick Kids in Toronto.
Thank you. Esophageal atresia TEF patients may be exposed to multiple general anesthetics, raising the concern for long-term neurodevelopment. The purpose of this study is to determine whether the length of anesthetic exposure correlates with neurodevelopmental outcomes for term EATF patients. The single-center retrospective review included term infants from 2000 to 2015 with neurodevelopmental follow-up. Developmental delay was identified if patients scored less than 85 or 1 standard deviation below norms for age in the Bayley Scales 3rd version. We identified 61 term EATF infants. 2/3 of them had bacterial association. On average, patients had 2 general anesthetics before age 3 years. Mean length of anesthetic exposure was 7.1 hours. Unfortunately, I couldn't show the graph, but it shows the distribution. There you go, the distribution of the EATF patients and the number of general anesthetics. We found that most EATF patients scored well in the Bayley scales. There was a slightly higher incidence of language delay. Of the patients who presented with language delay at age 1 year or younger, 75% of the patients participated in a language and speech program, while 67% of patients with motor delay underwent a physical therapy intervention. Following the use of interventions, 50% of the language delayed and 58% of the motor delayed infants no longer demonstrated delay at age 2 years and older. As shown in the graphs, length of anesthetic exposure did not correlate with cognitive, language, motor, vision, and hearing adverse outcomes at age 3 years. In summary, anesthetic exposure did not correlate with adverse neurodevelopmental outcomes for EATF patients at age 3 years. Neurodevelopmental assessment as part of a standard follow-up program for EATF patients will identify those with delays so that the use of targeted intervention will benefit infants who present with language and motor delays at an early age. Thank you.
It looks like you were comparing to your results to other complex surgical patients. Did those complex surgical patients also have anesthetic exposure?
With regards to the Bailey's tests, basically they're just compared to age norms. So it would be the overall comparison cohort would be to age matched. When we did compare our outcomes to neurodevelopmental assessments of, say, the complex heart population, our outcomes are better. Even the ones that had EATF and a cardiac defect, our scores seem to be okay, but the cohort is small.
Hi, Priscilla. Nice presentation. Do you think this is a neurodevelopmental problem, or do you think it's a speech and language therapy problem?
So do you mean the fact that the 20% of the population showed speech and language delay?
Yeah. I mean, do you think it's connected to actual central neurodevelopmental problem, or do you think that's connected with the fact they've got an upper GI problem?
I totally agree with you, Simon. I think it's an overall issue with their upper foregut. They're the same patients who have the eating, swallowing issues. Yeah.
Yeah.
Thank you.
Thank you. Our next presentation will be successful treatment of a Floyd type 1 tracheogenesis with trachealization and esophagotracheoplasty using 3D printed external bioresorbable splint, presented by Morgan Marol from Hershey, Pennsylvania.
Thank you. We have no disclosures. Tracheogenesis is a rare anomaly of congenital absence of the trachea. It occurs in 1 in 50,000 live births and is commonly classified using Floyd's classification. Unfortunately, a majority of patients succumb to neonatal asphyxia due to airway collapse. To date, there are only 11 reported survivors. Our patient is a female who was born at 41 weeks gestation with prenatally diagnosed congenital heart disease who developed immediate respiratory insufficiency on delivery, requiring positive pressure ventilation, intubation, and chest compressions. Following resuscitation, she continued to have multiple episodes of hypoxia and hypercapnia. Endoscopic evaluation at that time revealed incomplete vocal cords and concern for tracheogenesis. Esophageal disconnection and G-tube placement was then performed, followed by airway esophagostomy for tracheostomy tube placement, as well as creation of a spit fistula. After multidisciplinary and multi-institutional preoperative planning, as well as evaluation using 3D reconstructions as well as 3D printed models, the patient was brought back to the operating room at 5 months of age for repair of her AV canal defect, as well as airway reconstruction. Resection of the fistula and the esophagotracheal anastomosis were completed first. The 3D printed polycaprolactone bioresorbable splint was then placed for neotracheal support. Postoperatively, the patient had a favorable hospital course. She had improved respiratory function with no need for paralysis. Her post-op CT airway reconstruction revealed a widely patent neotrachea, and her post-op bronchoscopy revealed no collapse under suction. She was then discharged at 13 months of age with home ventilator support. In conclusion, we demonstrate that 3D printed polycaprolactone external splints may be a promising treatment option for patients with tracheogenesis. Thank you.
It's a great result in a difficult problem. Thank you.
Thank you.
Okay, we have maybe one question.
Sure.
Priscilla Chu from Toronto. So congratulations. I mean, that's a very challenging airway problem. And I think that the external splints really have made this possible. I do have a question about the fact that, you can tubularize something to make it an airway, but the airway clearance, the ability to, clear the secretion might still be a challenge. So just a follow-up question on how they're managing with airway clearance.
Sure. So preoperatively, just as a comparison, she was getting bronchial lavages almost daily, and then those continued after we ended up doing her airway reconstruction to progressively become more widely spaced out. So eventually every 3 days, every 5 days, to the point where we didn't need to bronch her further in order to help her with her airway clearance. So currently right now she's doing very well. She's at 18 months. We see her about every month, and she's had no, or at least from her parents, we haven't heard of any respiratory complaints thus far.
Thank you.
Thank you.
Our next presentation is cerium oxide nanoparticle conjugated with microRNA 146A treats lung injury by decreasing reactive oxygen species in bleomycin-induced murine model of pulmonary fibrosis by Sarah Hilton out of Colorado.
Thank you. Good evening. Today I'm going to tell you about CNP 146A, a potential therapeutic that can prevent and treat lung injury. ARDS is a common problem characterized by diffuse alveolar injury with disruption of the lung endothelial barrier. It can progress from exudative to fibroproliferative phase, leading to lifelong pulmonary fibrosis. Inflammation and oxidative stress play a role in the pathogenesis of ARDS, and novel therapies are needed. I'm going to focus on how CNP specifically targets reactive oxygen species. We conjugated the microRNA 146A to a cerium oxide nanoparticle, which is a potent scavenger of ROS. Anti-inflammatory microRNA 146A is primarily involved in the regulation of inflammation, and low levels lead to hyperactive response to injury and infection. Reactive oxygen species cause tissue damage and act as secondary messengers that can further amplify this inflammatory response. We have shown in vitro that inflammation and oxidative stress were decreased in both fibroblasts and macrophages after treatment. We thus hypothesized that mice treated with CNP miR-146A would have decreased reactive oxygen species. This model utilizes a toxic side effect of bleomycin to induce ARDS and fibrosis. The mice underwent intratracheal instillation of either bleomycin, PBS as a control, or bleomycin in a single dose of CNP miR-146A. We directly measure the ROS in lung tissue 1 week following injury with EPR, which is a technology similar to MRI that is able to detect unpaired electrons. Bleomycin-injured mice have more ROS than control mice, and mice treated with CNP miR-146A at the time of injury or 3 days following that injury have decreased ROS. Decreased inflammation in ROS translate to improved lung function. 2 weeks following lung injury, we ventilate the mice and measure pulmonary mechanics, and we see improvement in tissue elastance, compliance, and inspiratory capacity. In conclusion, CNP miR-146A is a potential new therapeutic to treat lung injury and prevent fibrosis by decreasing inflammation and reactive oxygen species. Thank you.
Questions?
Very interesting paper. My question is, how many times did you have to give the microRNA? The microRNAs are not very stable, so I was wondering whether you had to repeat the dose more than once, and how did you give it? What was the administration route?
So we give it just once intratracheally, so we know that unbound to the CNP, it is rapidly degraded. And I didn't show, we actually also will give just the microRNA by itself, not conjugated with the CNP, and we do not see the same improvement, probably because it is degraded. But we just give it one time, and we do an intratracheal instillation that's an aspiration method.
Okay, thanks.
As a reminder, please state your name and institution when you ask questions, please.
So what's your next step?
So we have a few next steps. The main things are trying to figure out a way to do multiple doses of this, so probably by nebulizing the drug, and then also looking at further like functional lung studies.
Thank you.
Thank you.
Our next presentation will be natural excretion of endoluminal springs after spring-mediated intestinal lengthening, presented by Dr. Taylor from Stanford, California.
Hi, good evening. Thank you for the opportunity to present. These are our disclosures related to this work. So short gut syndrome or short bowel syndrome, as we all know, is a debilitating condition with few effective long-term treatment options. Our lab has been focused on using distraction anaerogenesis to help lengthen the bowel. Through this process of mechanical stretching, we can induce new tissue growth. We do this by using a spring that is compressed into a capsule. That capsule is then placed into the bowel. We allow that capsule to erode and the spring to expand over time, resulting in significant lengthening. Our goal with this project is to develop a clinically relevant model for intestinal lengthening. And our specific aim for this project was to see if we could use dissolvable sutures to allow the spring to pass naturally from the intestines after successful lengthening, thus avoiding any additional surgeries. To do this, we use a mini Yucatan pig model. These pigs are about 9 to 13 kilograms. They undergo a laparotomy and placement of a spring into the intestine. The spring is held in place by 4 ochromic gut sutures that are placed on both sides. And our primary outcomes that we're looking for in this set of experiments was looking for intestinal lengthening, as well as spring position at 3 weeks and 8 weeks time. We follow these pigs with x-rays postoperatively. You can see that at 1 week, the spring is in place. And if I can get the arrow right, there are some intestinal clips that are telling us that the spring has not migrated. By 3 weeks, we see a twofold lengthening of the segment, and the spring is again in place relative to these clips. And by 8 weeks, all of these springs had passed from the lumen, but we still had a 1.7-fold lengthening of the bowel segment. When we looked at the specimens histologically, we found that there were significant differences based on whether or not the intestine had been treated with the spring. We quantified that there is increased crypt depth as well as muscularis propria thickening in the spring-treated segments at both 3 weeks and 8 weeks. So from this, we conclude that we can use dissolvable sutures to allow for the spring to naturally pass, and we can still achieve relative lengthening of the segment. In the future, we hope to use this in a disease model of pigs where we have created a shortcut model and also develop non-invasive techniques for placing these springs and plicating the bowel. Thank you, and I'm happy to take any questions.
Denis Petrov from Russia, Moscow. Thanks for your presentation. So according to several papers that your group has been publishing, you've been choosing spring parameters based on healthy porcine intestinal characteristics. So far, do you have any idea how to predict and choose parameters, spring parameters for pathological intestine, taking into account the level of inflammation, dilatation, and et cetera? Thanks.
Yeah. Thank you for your question. So we have done extensive work trying to develop a predictive model so that if you are going into the operating room to try and place this, you can look at the bowel and you can essentially refer to a chart where you can see, all right, what is the diameter of this bowel segment? What is the thickness of the bowel wall? What force do we need to actually generate this length? We have done some work creating a shortcut model where we resect 70% of the bowel in these pigs and have started to place springs in them, but we don't have yet a full developed prediction model essentially of what forces would be required to generate sufficient lengthening, but we're working on it.
Out of curiosity, was there any narrowing at the area of the bowel that you plicated? When you
Narrowing?
When you sacrificed the animals?
Yeah, so when we do these plications, we typically narrow the lumen by about 50%. We have, when we initially did more of a plication, we did have issues with obstruction in the bowel, but 50%, the content seems to be able to flow through without any obstruction.
Thank you.
The Copy London, thank you for your study. Have you looked specifically at the cell mechanism and which cells tend to proliferate more on this specimen, in the sense that do you have a distribution of Ki67 among the muscle and the epithelium, and how the cells really behave in that way, and if there's any difference between the segment that you stent and the other segment?
Yeah, thank you for your question. We have been looking into the mechanism behind this, trying to identify, are there particular cell populations that are more robust or growing faster? Is it muscle hypertrophy that's causing this, or hyperplasia? From our preliminary work, we're starting to see that there seems to be a rearrangement of the fibers and a hypertrophy of the muscle fibers, but we're still we're still working to figure out what exactly is driving this lengthening.
Thank you.
All right, thank you.
This session is dedicated to Dr. William Kiesewetter, who was APSA's 12th president and a founding member of APSA. This tribute video was prepared by Dr. Marcus Mellick from Pittsburgh.
We're very fortunate today to be able to speak with Dr. Adkins, who was a trainee under Dr. Kiesewetter and his partner for a number of years.
In 73, I actually came back to Children's to start my fellowship, and then I finished on December 31st of 74. Dr. Kiesewetter had hired me to be his associate. He came to Children's in about 1955. He was given the responsibility of making it an academic program. And when he came, he started a training program. In 56 or so, we had the opportunity to go to England, where he did dissections of stillborns and late-term fetuses who were known to have imperforate anus. And it was there that he developed the abdominosacroperineal surgery for imperforate anus, known in the States as the Kiesewetter operation. It was that experience that really gave him an interest in a substantial amount of fame nationally. Dr. Kiesewetter had this feeling that it was the responsibility of American surgery to train people from other countries, and he certainly followed that in his approach with pediatric surgery at Children's. He always had what we referred to as an international fellow. Usually those fellows came to spend a year, and his expectation was that they would return to their home country where they would be able to train other pediatric surgeons there. As soon as Dr. Kiesewetter arrived, he established that any newborn who had an operation, everybody came in. If you were doing anything other than being in church, you were supposed to come in to either assist or to observe the operation on the newborn. And that expanded substantially the exposure to newborns that we had. What he had invested in that training was kind of culminated in 79, when he had the long-term follow-up conference for pediatric surgery, and the people came from everywhere. It was an extremely impressive group of surgeons. Morio Kasai from Japan, everybody from the U.S., it seemed, were here. And as far as he was concerned, that was his crowning glory. As long as I was an associate of his, for me, he was Dr. Kiesewetter. And when he was referring to Mrs. Kiesewetter, he never referred to me as Grace, but he referred to her as Mrs. Kiesewetter. He was extremely formal, which is not to say that he wasn't friendly. He was very friendly. When he was elected president-elect of APSA, he was extremely happy. He cherished APSA as a professional organization, and he felt that that was his highest honor in his life.
Our next presentation will be the dual-stage pathway for closure and colectolectrophy, successful evolution in collaborative surgical practice, presented by John Jamin from Baltimore.
Thank you for this incredible opportunity. So think about colectolectrophy, it's a very complex birth defect. So it consists of a omphalocele repair, abdominal wall, and bladder closure, for which an osteotomy is oftentimes utilized to mitigate the tension from a wide pubic diastasis. And so the dual-stage pathway was introduced in 1995, and it incorporates the staged osteotomy into the closure of colectolectrophy. And with that, patients who have a diastasis greater than 4 centimeters, they undergo a pelvic osteotomy, an external fixation placement, and then rotation of the pubic bones into opposition before placing the bladder deeply into the abdomen. In patients with less than 4 centimeter diastasis, they undergo osteotomy the same day as bladder closure. And so in order to assess the DSP, what we did is we looked at 2 equal time periods before and after its introduction. And we looked at the outcome of closure as well as the complications. And here we have a picture pre and post bladder closure of colectolectrophy. What we found in our study is that there were 34 successful colectolectrophy closures in the DSP cohort. There were no closure failures. Before DSP was introduced, 14 out of 16 closures were successful, with a 88% success rate. The complication rate between closure groups were similar. However, there was a slight increase in orthopedic complications, although this was not statistically significant. The majority of these were superficial pin site infections. Also, since 1995, patients referred for closure have had a larger pre-closure diastasis, which represents an increase in patient complexity. So, in conclusion, sorry, having trouble with this. Okay, so in conclusion, the DSP provides a secure method for patients with a large pre-closure diastasis. It comes with the caveat of a slight increase in minor orthopedic complications. Thank you for your attention, and at this time, I'd like to open the floor to questions.
Andrea Bishop, Children's Hospital, Colorado. Since this is a pediatric surgery meeting, I think we were wondering, what do you do with the bowel? What's your approach, and when do you deal with that?
Okay, that's a very good question. So the omphalocele repair, that occurs during the newborn period, and that's very important for nutritional growth of the child before they undergo this major operation of placing the bladder deep into the abdomen. So that's done in the newborn period, and then I think part of that is what then leads to the success of the bladder closure as well.
Hi, John Gearhart from Baltimore. Thank you, Andrea. John's a medical student. He's worked hard on this project. In the newborn period, we close the omphalus seal, preserve all the bowel that we can, bring the bladder halves together, whether it's colon, small bowel, hindgut, cecal plate, whatever you want to say, but we preserve all bowel, repair the omphalus seal, and bring the bladder halves together. Our pediatric orthopedic surgeon who really developed this feels that by the time they're around a year of age, they have enough cancellous bone, then they can tolerate a transverse innominate vertical iliac osteotomy, put the fixator pins in, gradually crank them together over 2 to 3 weeks. So then you do your soft tissue surgery is done, the bladder, urethra, so forth, and then they put the fixating device on for 6 weeks. And it's worked really well, and I think that we as pediatric surgeons and pediatric urologists have learned from our orthopedic colleagues that recapitulation of the pelvic bony complex is really important to enhance everybody's success in this group of patients. Thank you.
Thank you.
Our next presentation is Suction Rectal Biopsy is Safe and Accurate in Premature Infants by Devin Halloran from Columbus, Ohio.
Green button here.
Yep. Green button. Big one. Big green button.
Thank you. Consider the case of a 7-day-old, 1,800-gram, X33-week infant with abdominal distension, failure to pass meconium, and a contrast enema that cannot rule out Hirschsprung disease. When would you biopsy this patient? The objective of our study was to assess the accuracy and safety of suction rectal biopsy in preterm infants. And to do this, we performed a retrospective cohort study of patients under 37 weeks adjusted gestational age at the time of suction rectal biopsy. Biopsy findings were then compared to the final diagnosis in the overall cohort and then separately for the subset of patients under 2,000 grams. We identified 49 patients over the study period. The median age was 35.5 weeks, and the median weight was just over 2,000 grams. 44 patients had ganglion cells present on biopsy, while the remaining 5 patients had no ganglion cells on biopsy. Of the patients with ganglion cells present, none were later diagnosed with Hirschsprung disease at a median follow-up of 3 years. While in the group of patients with ganglion cells absent, all 5 underwent a pull-through procedure, and the diagnosis of Hirschsprung disease was confirmed on final pathology in each case. We then looked at the subset of patients under 2,000 grams, knowing that some surgeons are hesitant to biopsy below this weight. We found similar results in this separate cohort. Overall, the sensitivity, specificity, positive predictive value, and negative predictive value was 100% for each, demonstrating that this can be performed accurately in a preterm cohort. Additionally, we identified no complications over the study period, demonstrating that this can be performed with minimal risks. And these results held in the subset of patients less than 2,000 grams. In conclusion, suction rectal biopsy was accurate in preterm infants, even those under 2,000 grams, and can be performed with minimal risks. It may be time to reevaluate our criteria for suction rectal biopsy in preterm infants. Thank you, and I'm happy to answer any questions.
Andrea Bishop, Children's Hospital, Colorado. I was just wondering, how do you put in the equation the experience of the pathologist? Because yes, it can be done, but I think I am mainly concerned about the patient that receives an operation and then later we find that they never had Hirschsprung, and that's irreversible.
That's correct, and thank you for your question, Dr. Bischoff. You're absolutely right. In Columbus, we have a very experienced staff of pathologists who have very high volume experience with Hirschsprung disease. We didn't specifically look at that in our study, but there is literature suggesting that a pediatric subspecialty in pathology adds the diagnostic yield of diagnosing Hirschsprung disease. So I agree that you would expect a higher accuracy with more pediatric experience, but that's not something that we looked at.
Erin Perone, Ann Arbor.
What gun did you use? I may have missed it.
Yes, we use the RB1.
Okay, and so what you were able to go? Did you use the manometer? And did you use a lower threshold for the lower weight?
No, we use the standard technique that we use in older children, approximately 1 centimeter above the dentate line.
No, right. But did you use a manometer when you used the RBI1 to know the pressure you were pulling?
No, not typically. But again, that's not our standard practice. That's our standard practice.
We have time for one more question.
Cipetitoni, Milano, Italy. Thank you very much for demonstrating this, the possibility to have a very early diagnosis. But my question is, what is the importance of the clinical point of view? Do you think that is not dangerous? You can achieve a diagnosis if you have a pathological expertise, but do you think it's really useful on a clinical point of view for these small children?
Thank you for your question. I don't think that the real clinical value is in diagnosing Hirschsprung disease in the neonatal period. I think that the real benefit is in excluding Hirschsprung disease in patients who are preterm, so you can shift your focus to other diagnoses.
Thank you.
Thank you. Our next paper is the variability of the transition zone length in Hirschsprung's disease, presented by Dr. Thakkar from Great Ormond Street.
Thank you for the opportunity to present. We have no disclosures. So the surgical management of Hirschsprung's involves pulling through ganglionic bowel, and there are patients who have persistent postoperative obstructive symptoms, and in this cohort of patients, you would potentially be worried about a transition zone pull-through. The length of this transition zone has been reported in the literature to be usually less than 5 centimeters, but anecdotally, we found that this was more in our experience. So we wanted to actually evaluate the length of the transition zone in all patients undergoing primary pull-through surgery at our institution, and then also assess the impact of this in terms of technical completion. So this figure over here very beautifully illustrates the bowel essentially moving from distal to proximal, so distal on the right-hand side and proximal on the left. And it just shows you the distribution of ganglion cells where you don't have the necessary complete circumferential presence of ganglion cells in the transition zone. So if you were to take a biopsy where I've put my blue arrow, although you'll see some ganglion cells at that part, the rest of the bowel will not have it and you will have a transition zone pull-through. So we look back retrospectively over a period of 6 years, and in all of our operations, we do send intraoperative frozen section biopsies, but not all surgeons in our department review the proximal donut prior to completing the pull-through. So we had 48 patients in our study. The majority of these patients were male as expected, but we actually had more than half of our patients did have a stoma prior to their surgery for different reasons. The median transition zone length in our study was 1.7 centimeters, but as you can see in the range, the longest transition zone length was nearly 23 centimeters. And interestingly, more than a fifth of our patients had a greater than 5 centimeter transition zone length. This chart over here just illustrates the relationship between the length of the aganglionosis on the x-axis and the transition zone length on the y-axis. There's been a recent paper from Prem Puri's group which has said that if you have a longer length of aganglionosis, you potentially also have a higher transition zone length. We saw a very weak relationship, which is not significant in our study. So in terms of technical completion, of the 48 patients in our study, in 25% of them, we did review the donut prior to completing the pull-through. And of those, 3 times we actually found that there was transition zone in the proximal margin, so we were able to avoid a transition zone pull-through. Whereas in 75% of the patients that did not have this reviewed, we ended up with 3 transition zone pull-throughs. So in conclusion, the length of this transition zone is highly variable, and it can be much larger than the 5 centimeters that we traditionally think about. So what we would do is advocate a circumferential intraoperative frozen section review of the proximal donut prior to completing your pull-through. Thank you very much.
So what did you do with the 3 transition zone pull-throughs?
So one of the patients has had a redo. The other 2 patients one of them has just been discovered and is coming back for a biopsy to check and see what the results are. The 3rd patient is currently asymptomatic.
This is Alberto Peña from Denver, Colorado. We are aware of the problems that are presented in many meetings concerning the pulling down a transition zone. So far as I remember, we never had a problem pulling down a transition zone, because in Hirschsprung disease, the purpose of the operation is not only to remove the aganglionic segment, but also we have learned that it is extremely important to remove part of the most dilated proximal normal ganglionic bowel, because a very dilated colon translates into severe constipation. A dilated hollow viscous has poor motility, and therefore we have learned to remove the aganglionic segment plus a significant portion of the normal ganglionic dilated bowel, and so far we never had a problem with pulling down and so-called transition zone.
Thank you very much for your comment, Dr. Peña.
Our next presentation is Factors Predicting the Need for Vaginal Replacement at the Time of the Definitive Reconstruction of a Cloacal Malformation by Alejandra Villanova Sanchez out of Madrid and Columbus.
We don't have any disclosures. Cloacas has been classically divided into 2 different groups based on their length of the common channel. The longer ones usually need a urogenital separation via posterior sagittal approach combined with an abdominal approach. Many on this group need a vaginal replacement. To our knowledge, there is no established criteria which predict the need of vaginal replacement in these patients. So we aim to determine if anatomic factors can predict the need for vaginal replacements in patients with cloaca. In order to do so, we retrospectively reviewed the chart of patients who underwent primary cloaca repair at our institution from 2014 to 2018. All of our patients underwent a multidisciplinary evaluation, examination under anesthesia with cystovaginoscopy, and 2D and 3D cloacograms with which we measured the length of the common channel, the length of the urethra, and the length of the vagina. The type of reconstruction was guided by the length of the common channel and also by the length of the urethra. We have presented this algorithm previously at APSA. We evaluated the following variables, and we compared them between the group of patients who required the vaginal replacement with those who did not. We operated on 50 patients. We performed 17 total urogenital mobilizations and 33 urogenital separations. In the TUM group, no patients required a vaginal replacement. In the urogenital separation group, we performed 19 vaginal replacements and 14 native vaginal pull-throughs. Comparing all these variables, we didn't find any statistical difference between these 2 groups. Regarding the vaginal length, in the vaginal replacement group, the vaginal length was 4.2 centimeters, while in the no vaginal replacement group, the vaginal length was longer with a median of 6.6 centimeters. In this case, we did find statistical differences between these 2 groups. So we can conclude that preoperative measurements of the common channel of the urethra and also of the vagina are essential for operative planning. Vaginal replacement can be predicted by the need for urogenital separation and also by short vaginal length. Thank you very much.
Very nice presentation. In those that needed a vaginal replacement, what was the replacement of choice?
We always do a colonic vaginal replacement at the time of the primary reconstruction.
Thank you very much.
Thank you.
Our next presentation is the long-term impact of a bowel management program in treating fecal incontinence in patients with anorectal malformations, presented by Dr. Richard Wood from Columbus Children's.
Mr. Chairman, ladies and gentlemen, we have no disclosures. Bowel management for anorectal malformations taking the form of a week-long outpatient program with the use of x-rays in conjunction with stimulant laxatives or enemas was established in the literature in 2009. Results at that time were reported at 1 week, and in the subsequent decade, no long-term results have been reported. The objective of this study was to assess the effectiveness of bowel management at 1 year, using standardized definitions, parent or patient-reported outcomes measures, as well as quality of life assessments. We did a retrospective review 1 year after bowel management for all patients with ARM between 2015 and 2017. Clean or continent, depending on whether patients were on laxatives or enemas, was defined as 1 or less accident per week, according to the Rome criteria. In addition, we did a Baylor continence score on all patients, as well as the Vancouver elimination score. Furthermore, patients underwent PedsQL testing. We had 149 patients with anorectal malformations were treated, 90 of whom were male. The median age was 6.6 years. All patients are soiling prior to starting on bowel management, and 97 were treated with enemas and 52 with stimulant laxatives. Our results show that 75% of patients overall were clean at 1 year after bowel management. When we look at this in more detail, we see that the patients on enemas were 80% of whom were clean, while those on stimulant laxatives, 65% were continent. And this was statistically significant. When we look at the results a little bit more with regard to patient-reported outcomes, we see that, as expected, the Baylor scores show significant improvement. However, what is interesting is to see that the Vancouver elimination scores are also significantly improved. Now, the definition of lower urinary tract dysfunction is a Vancouver score above 12, so we were able to effectively treat lower urinary tract dysfunction by purely doing bowel management. We also noticed that the pediatric quality of life scores do not improve. In conclusion, bowel management is effective in patients with anorectal malformations. It is durable at 1 year, and more research is required to understand the reason why PedsQL does not improve despite improved functional outcomes. Thank you very much. I'll be happy to take any questions.
Any hypothesis as to why the quality of life measurement wasn't improved?
Yeah, I mean, I think bowel management is very effective, I think we find, but it does place a burden on families. And I don't think that the PedsQL is necessarily a fine enough instrument. I think there are other instruments out there. There's one that's been developed by the Outcomes Lab in Columbus looking at patient experience. There's the SynCFIS, which has been developed looking a little bit more detail at these kinds of patients. And I think over time we'll work out that we are definitely making improvements. We need to understand what the patient experience is like, to understand what those improvements mean for families and kids. And I think we also need to realize that maybe a generic, broad PedsQL is too blunt an instrument to really understand the effect on their quality of life. So there's work being going on to try and understand that in more detail.
Thank you. Very nice presentation.
Thanks.
Our next presentation is real-time magnetic resonance imaging and cystoscopy to avoid misplacement and roof in anorectal malformation corrective surgery by Matthew Rawls from Ann Arbor, Michigan.
Thank you for the opportunity to present. We have no disclosures. So any male patient who comes to our colorectal clinic with a high imperforateness or anorectal malformation is evaluated for MRI-guided repair. This basically shows our setup where our children are then placed into a MR-compatible fixation device. The MRI machine is then brought into the operative suite. Diagnostic scan is done, where a group of us sit around, including radiologists and other experts, discuss where the musculature on that individual lies and what the best path for anal canal should be. At that point, Dr. Jarboe, one of the other co-authors and my partner, who's also an interventional radiologist, climbs into the MR bore with a sight on the monitor, can actually tell where he's going to place that needle into that previously described path that we talked about. So here's a video showing what we do. This is not sped up or slowed down, but we do have some pauses to show you exactly where the needle is going because it's a little difficult to see. So we're coming up through the superficial sphincter complex, getting deeper into the pelvis. Once we get to the pelvic floor, then angle the needle backwards, drive it further into the pelvis, that we can then find it during our typical laparoscopic dissection. The MRI is then wheeled out of the operative theater. We then place the child in lithotomy position and move forward with our standard laparoscopic takedown of the fistula. Here we have done most of the dissection. We've added now using a cystoscope in the urethra at the time, so you can see that can basically squeeze on our fistula to see where we're basically not narrowing the urethra at all, but also not leaving any remnant tissue and having a long-term or remnant of the original fistula. And we've only done 4 patients in this way. 1 had urinary retention. Our biggest challenge, I think, is to decrease our operative time. There's a switching of positioning that happens that we're trying to work out a way kids under anesthesia for a less amount of time. We have 4 more in the next month, so we're hoping to get that down. So with that, thank you, and I'm happy to take any questions.
Kurt Heiss from Atlanta. Nice presentation. When the MRI preoperatively shows the pelvic musculature and around the levator sphincter complex to move back and forth like leaves in the wind, how does Dr. Jarboe and you address that chaotic arrangement of pelvic musculature?
Yeah, so what you're basically pointing out is that we're only using a sagittal image to drive the needle through, which is a difficulty for us. However, it's basically at that point, what we can do is place the needle what our best guess is. If we need to shift one way to the left or the right, then we can repeat a diagnostic scan afterwards with our needle in place. We've only had to replace our needle once, and these are only the 4 that we've done with cystoscopy. I think our number is now up to about 14 or 15 with the MRI itself, so.
Steve Rothenberg, it's very interesting, but I guess I'm struggling with trying to see what the benefit is. I mean, as you know, the studies have shown through it with the laparoscopic pull-through for a high imperfect anus that in most studies, when you study them post-operatively with MRI, the pull-through is actually through the center of the sphincter, and we do that by stimulating the external sphincter with a stimulator, making a small incision. That part of the dissection is very limited. It's less than 1 centimeter. And then looking in laparoscopically and seeing your needle come out in the center of the levators. So I'm not sure what the added advantage of doing this is, because it seems like it's the same result. You're getting the same view, and I'm not sure how the needle directs you any better than stimulating the external sphincter, because that's really what you're trying to get through the center.
So it's a great question. It's a great point. I think that you make again, a very good point as far as the anal canal with the external sphincter muscles. However, we think that the pelvic floor gives us a little bit of advantage to maybe identify puborectalis, which is maybe shortened and narrowed. And we feel like we can, at least in our hands, maybe in yours, you're better than us, but we feel like we can go up and get a little more of that pelvic floor musculature with the MRI assistance. Thank you.
What's the longest follow-up you have, and do you have a control group? Because the bottom line is going to be, is there any functional difference?
Right, yeah, we don't have much long-term data yet. Our kids are not old enough. As of now, anytime one of these kids is under anesthesia for anything else, we're doing ultrasound to look for any levator muscle, any puborectalis muscle that we can find. That's going to be a few years down the line. Of course, the proof is going to be in the pudding of when these kids are having continent bowel movements and things like that. So that's in the next few years, hopefully.
Thank you.
Thank you.
And the honor for the last presentation of our first day goes to Dr. Krista Grant from Penn State Hershey, once again, for laparoscopic Morgagni hernia repairs with an intuitively controlled articulating instrument.
Thank you for the chance to share our work. This is a video.
This video demonstrates two cases in which a novel articulating instrument was used to repair Morgagni hernia. The first case shows an uncomplicated repair in a 6-month-old who had been incidentally diagnosed during hospital admission for a pneumothorax after birth. Preoperative imaging demonstrates the hernia. After taking down the falciform ligament, electrocautery was used to abrade the peritoneal edges of the hernia. The sac itself was not removed. The hernia edges were then closed in a running fashion using a V-lock suture. You can see that the instrument's articulation permits perpendicular sutures to be placed under direct vision to avoid injury to the pleura or pericardium. A second imbricating layer was added for reinforcement. The final repair is shown here. She recovered well and was discharged home the following day. She's doing well at her 3-month follow-up, which is ongoing. The second patient is a 16-month-old who had an omphalocele repaired on the first day of life. She was then diagnosed with a diaphragmatic hernia during a URTI at 12 months of age, and elective repair was planned. Her imaging at diagnosis is shown here. However, in the interval, she presented with vomiting and was noted to have distended loops of bowel in the chest. After NG decompression, urgent diagnostic laparoscopy was planned. There were minimal non-obstructing adhesions to her anterior abdominal wall related to her previous omphalocele repair that were sharply laved. Most of the small bowel and part of the large bowel were then reduced from the chest. Note the distended loop of distal small bowel. Several small band adhesions were noted. They are best demonstrated here. The point of obstruction was due to adhesions to the terminal ileum. These were taken with a combination of electrocautery and sharp dissection, as there were adhesions between the ileum and the right atrial appendage shown here. After the bowel was reduced, it became clear that there was no hernia sac nor pericardium. However, bilateral pleura were intact. A piece of 6 by 7 centimeter Gore-Tex was cut to size. It was anchored in position with interrupted silk sutures at the 12, 3, 6, and 9 o'clock positions. Again, the intuitive articulation permitted these sutures to be placed carefully in the limited domain available, which was exacerbated by her bowel obstruction. Then, a running V-lock suture was used to circumferentially secure the Gore-Tex mesh to the diaphragmatic rim in the anterior abdominal wall. Care was taken to ensure mediastinal structures were protected. Suturing can be carried out with a single driver, thus utilizing the free hand to provide exposure and facilitate safe suture placement. This twirl function permits rapid running sutures in any direction. This patient's Morgagni hernia with a pericardial defect, in combination with an omphalocele repaired on the first day of life, led to a diagnosis of incomplete pentalogy of Cantrell. She had no sternal abnormalities, and no major cardiac anomalies were noted on echocardiogram completed on the first day of life. The final repair is shown here. She recovered well in hospital and was discharged home on postoperative day 4. X-ray demonstrates a few small anterior mediastinal lucencies, which may relate to mesh eventration, small recurrence, or postoperative change, and will continue to be followed closely.
I'll take any questions.
Daryl Cass from Cleveland. Thank you for sharing. Those are beautiful videos. And I think the purpose of the paper was to demonstrate that instrument, which is pretty damn cool.
Correct.
My question, though, is on the first case, what were you sewing to with that Morgagni repair? That was like a pretty small Morgagni repair.
Mm-hmm.
Just because I think that anterior tissue is kind of nothing.
Right.
And I think a lot of us go through the abdominal wall and tie our knots extracorporeally or whatever to ensure a lack of, and do you have long-term follow-up on that first case?
Correct, thank you. So that first case is essentially analogous to the way that you're describing, where essentially suture passers are used to put silks through or anything like that. And we do sew to essentially the abdominal wall. Externally, you can see our needle coming up almost to the subdermal layer, so it's the same repair. In terms of long-term follow-up, she has been seen again and has not had a recurrence.
How long?
About 9 months.
Thank you for your attention here.
Thanks.
Anyone